For us, the main rationale for using interpersonal group therapy for addictions is that we think that among other benefits, it builds resilience to some of the best evidence relapse precipitants, interpersonal conflict, and what Miller and Harris have described as a state of demoralisation and alienation. We like to think of this model of group therapy as interpersonal relapse prevention, which you will notice is the subtitle of our training package. It is the most suitable group therapy for those who are entering and developing recovery. For example, it is frequently used immediately after detoxification, although we see no reason to think it wouldn't be beneficial to those starting their recoveries supported by a substitution pharmacotherapy. As recovery progresses, the group model remains relevant and forms a useful aftercare intervention for those who have completed their rehab programs. There is also reason to think that this form of therapy might help people make the best use of mutual aid groups, although the form of group interaction is very different in those groups. Firstly, it's important to point out that complex and sophisticated social relationships are a defining feature of the human species. Our place on the evolutionary tree is as the specialist in interpersonal relations. Our ability to form relationships may well explain our species' survival and eventual dominance, and we now have a global social community with the ability to instantly communicate across continents. There is evidence that we are biologically set up to attach to others and have a fundamental need to be part of social groups. It has also ensured that we will express distress and unhappiness when we feel outside of social groups. It's a noted characteristic of addiction to drugs and alcohol that an obsessional relationship with substances almost always becomes harmful to human relationships. Some people begin addictive careers before ever fully developing the ability to have supportive adult relationships. But even those who become addicted later, by the time they are ready to seek treatment for their problems, years of obsessional drink or drug use is likely to have caused significant harm to any good relationships that may have developed. In addition, people forget how to get their social needs met outside the context of drink or drugs. Substances invariably become a mediator in all major relationships. They may be a shared interest, or used to get close to someone else, or they may be used to keep people away, or to express anger, or to punish others. There are many ways substances become pivotal in the relationships of those seeking help. Learning how to have supportive, mutual and satisfying relationships free of drink and drugs is a key task of recovery, and the main aim of this form of group therapy. Interpersonal group therapy doesn't assume that people with substance misuse problems all share a particular profile or personality type, but instead identifies and directly addresses relevant problematic interpersonal behaviour, whether that be isolating, ineffective ways of trying to be liked by others, intimacy issues, or any other maladaptive relational style. An important characteristic of interpersonal group therapy in relation to other approaches is that it need not be too anxiety-provoking. Research has shown that people who are in early recovery from addiction are significantly more anxious than the general population, and approaches that focus on intentionally stimulating difficult feelings, on heavily challenging people, or intentionally provoking transference are likely to be too much for many clients to relax and trust the group process enough to express themselves and interact as freely as they would outside a therapy group. This natural expression is vital if the problems that people need to work on are to become available to the group for therapy. For interpersonal group therapy to be helpful, it's essential that clients come to understand their substance use from a relational perspective. If they come to see how working on their relationships will support their recovery, it is far more likely that they will invest in the group. For this reason, making the model of therapy explicit at the outset is vital, as this helps clients set their goals as relational ones that groups can help with, rather than making practical, out-of-the-group goals that tend not to be amenable to group therapy. If clients learn to value sharing themselves with others and are able to develop supportive relationships, they are again also more likely to gain from affiliation with 12-step or other mutual aid groups, and the evidence available suggests that it is those who become socially active in these recovery communities that can benefit the most. The treatment setting you will be witnessing is offering interpersonal group therapy as part of a wider structured day program. Without the support of other group and one-to-one interventions, working interpersonally might well be too challenging for many clients, as these groups often end with some people feeling exposed or vulnerable. If there are other therapeutic activities later in the day, this gives people a chance to process their feelings and be less vulnerable to relapse as a result.